All right, it's 12:16. We've got about 70 people on, so why don't we go ahead and get rolling just to keep up with everybody's time. So thanks everybody for joining. Hope everyone had a lovely weekend, safe at home and away from everyone. We will go ahead and dive right into the numbers game. So as of Saturday, and I don't know if that is still the case, Monroe County had the designation, or the surrounding area had the designation as the highest rate of rise over the preceding 10 to 14 days of any area in the country. So that was definitely not a designation that we were looking for. Nationwide, we have had a 20% increase in our viral case rate week over week. So compared to about 7 days ago. On the whole, you know, the numbers, the graphic doesn't look quite as impressive, but when you look at kind of the historical trends, we are now trending from a fatality rate that is right at the worst peak of April. And we have had the highest of the 7-day rolling average mortality rate, I should say. We did on Friday set the record for most number of fatalities in a day nationwide. And unfortunately, that doesn't seem to be quieting. Dr. Fauci has been all over TV and radio for the last couple of days. He is still predicting mid-January to be the concerning timeframe, that could potentially be the worst. And his biggest concern, as we've talked about multiple times, is the trend that we're seeing from Thanksgiving potentially superimposed on indoor gatherings from Hanukkah and Christmas that would then materialize in that early to mid-January timeframe. So they're trying to redouble their efforts to encourage people to mask, distance, and avoid indoor gatherings. Right before coming on to here, I was trying to garner everything I could from the governor's press conference. In the orange zone, we have been ticking up slightly as far as our percent positivity in the Monroe County area. The yellow zone is down slightly from Saturday, where we were at the peak, but still hovering above 7%. As a whole, we are at 7.01% for the greater Rochester area. Statewide, we're actually doing quite well. So New York State is the fourth lowest positivity rate in the country, behind Maine, Hawaii, and one other state that I will tell you if you guessed, but I can't remember off the top of my head. I'm sorry?
Vermont.
There you go. Good job. We are still doing well statewide, but unfortunately, as the governor pointed out in his conference today, the Finger Lakes and downstate New York City area have exactly flipped from where we were in April. To where in the beginning, the Finger Lakes were the low incidence rate and New York City was the high. We are now driving the incidence statewide, with Erie still a problem and Ontario County actually surging in the last 3 or 4 days as well. So a lot to kind of keep an eye on. I think the southern tier, as Nick Apostolaris' data will show here momentarily, has been largely affected by facility, so nursing homes in particular, rates of positivity. We continue to hear of nursing homes across the region that are going on pause as far as being able to accept patients. We have heard of several facilities that will have what I will call quote unquote emptied out, especially assisted living facilities that are sending 10 to 20 patients at a time from the facility to the hospital because of exposure. So there is an effort that I will go ahead and discuss now going on across the region, at least in the facilities that the UR Medicine Geriatrics Group is supervising. So that constitutes about 29 facilities across the region. They are working with the emergency response teams. So Jeremy Cushman in Monroe County, I think he also may head up Livingston County, if I'm not mistaken. So he's the EMS, he's the ED physician that heads up EMS. I think he actually covers several counties across the region. But they are working for these assisted living facilities to partner so that if a facility calls and is looking to transfer 3 or more patients from the facility, the geriatrics group will actually do either an on-site or telehealth assessment of the patients in partnership with EMS, who is physically there, to assess patients and see if they really need to be transferred. And then they will be in contact with you guys, as they are the physician of the facility. They would be in contact with you all if you're the primary care of record, to let you know if they did or did not recommend transfer of a patient. But we've seen a lot of facilities where a patient may have come into contact, maybe they went home with their family for Thanksgiving, come to find out that patient is positive, and then facilities have sent 10 or 12 patients at one time to the ED because those 10 or 12 came into contact with a patient who may have had a positive contact, even though none of those people are materializing symptoms. So just know that there is effort to try to avoid that mass hospitalization, because in many ways that may be worse for these patients, and certainly overrun the hospitals. The governor has again highlighted the concerns about the rate of hospitalization and the potential of overrunning the hospitals. He mentioned, and I don't know much in the way of details of this yet, but he mentioned that they are now invoking the 25% capacity issue for the hospitals, that they must have 25% bed capacity. Now, what I don't know is, before, all hospitals were instructed that they had to have a plan for how they could reach 50%. What I didn't understand from the conversation was he invoking that you had to have 25% capacity available today? So I'll have to go and look more into that. I'm sure we'll get more details. I didn't get to hear the whole conversation. I see Amy Pollard's on, so maybe she has better understanding of that than even I do. But that's obviously oh, go ahead, Amy. You're on mute if you're talking. Amy, you're on mute. Oh, sorry, maybe she wasn't talking to me. Anyway, so we'll find out more about that. But what he had said is that if any hospitals if a region cannot meet the capacity criteria, that they would go on what he's calling a New York pause by region. So that would close down dining, that would close down bars, that would be kind of an immediate red impetus that would go out immediately if the hospitals are not able to meet their capacity needs. So I'm sure we'll hear more about that, as we are trending the highest right now in the Finger Lakes region of any area in the state. So if anybody's going to get a pause, it would be most likely to be us. But he did reiterate that even with that pause, that as long as transmission in schools remains low and they're meeting that 20 and 30% testing criteria of yellow and orange areas. Oh, perfect. There you go, Dr. Aaron Farney. Perfect. Thank you very much. That schools would stay open even if they did go on a pause. So that remains true. So with that, the next thing I wanted to move to, actually, we can show the graphics from Nick Apostolaris. I don't think the graphics that I normally show are really telling anything any different. The hospitalization rates are going up, as we discussed, but otherwise there's no particular trends that are different. Same old, not good, but same old that we've been looking at. I'm sure probably within the next couple of days we'll have reached 7 days of total data to move that graphic a little farther, which may show a little bit. So you can see Monroe has really surged here in the last week or so, as we've been talking about. Certainly the southern tier counties are seeing surges as well, and you can see in that light blue the Ontario County, which had been relatively quieter. Ontario County has also had some surge going as well. So lots to be concerned about. You know, it's a mixed bag. It's nursing facilities, assisted livings, group homes, private parties that still seem to be the biggest point of microclusters. But you know, it's creating the Moose Lodge is definitely not helping. That's exactly right. Any Moose Lodge that has a bar should be shut down immediately. Those are like automatic hot zones, it appears. So that's where we stand with that. In regards to testing, I believe it was Friday that we reached 3,800 tests processed at U of R. That was our peak number that we had processed through the U of R and affiliate hospitals. The moose is definitely on the loose. You're right about that. I think the weekend was a little bit quieter, as is not uncommon. One thing that I did hear over the weekend, as we talked about previously, with Rochester Regional having a little bit faster turnaround time of COVID testing, uh, it appears that they have now saturated their capacity as well. As I understand it, they informed their primary care teams that swabs that were obtained in the ambulatory setting were likely to be sent to Quest Labs with a return time that again would be in that 5 to 7 day turnaround. I know this because my wife works for Rochester Regional. So, just know this cat and mouse game of who's in the lead. It's turned once again, but we are still ever increasing our capacity. But obviously it's not keeping up with the demand and incidents that we're seeing right now. So we are going to see probably further delays in some of the ambulatory testing. As of right now, the U of R is not sending out any of its testing to out of town labs. So that processing time is not ideal, but it'll still be better than what we're seeing from Quest and the like, which were taking upwards of 7 to 10 days at one time just a couple months ago. On that note, we did get some reasonable good news. So U of R did get for some of the affiliate hospitals and labs, they were able to get some LEIT testing machines implemented that are at least on order, that I think if not will be coming in shortly. I got word on Saturday that it appears that we will likely get 10 LEIT machines from Roche probably by mid-January. So I'm hoping, in fact, I was really hoping I would hear from them again this morning to get definitive answer on that, both for number and time frame. Obviously, I've been arguing to get as many as we can, but it sounds like 10 will likely be what we can get. And then for what they alluded to before, every 30 days, there may be more units that would come available. So obviously the goal would be to try to disperse those equitably across the region amongst all of you who expressed interest. I realize many of you had asked for multiple units. Obviously with 10, we won't be able to give individual practices 5 or 6 at a time. But my hope is we'll be able to continue that tap going forward, and maybe every 15, 30 days, as Roche releases more, we can continue to keep those rolling out to all of you. So I just wanted to let you know that that does look more likely now than it did even before. Number of test kits, from what I understand, come January, they are going to be in much better shape from Roche. I know Cepheid continues to be very limited, and in many ways, the machines are outpacing the availability of the test kits. For Roche, it actually seemed that the test kits will keep pace and actually be in greater surplus come January. So right about the time we would start getting machines, it seems like the test kits will become more available. Again, I can only report out what they tell me, and so I can only imagine that those test kits won't be in quite as great of availability, but it doesn't seem like that's their greatest concern at the moment. Roche is more concerned about the availability of machines. Cepheid is more concerned about the availability of test kits. So take that for what it's worth. There is no perfect solution at this moment, unfortunately. I did have a couple folks reach out to me again about antigen testing, and with the ever increasing rate of positivity, would antigen testing be more of a consideration now? LJ is already shaking her head, so she beat me to the punch. At this moment, that answer remains no. Even though the antigen testing is being used in schools for asymptomatic testing, it is not considered at this moment to be acceptable for any determination about return to work, positive or negative, have disease, anything like that. So for the moment, it is lab-based PCR, Cepheid, or LEIT. And trust me, I will be the first one to let you know if that calculus changes. Several folks have asked, should we go ahead and start buying antigen testing just to get ahead of the curve because we know what could be coming, like what we saw with Cepheid and LEIT. I will be very forthright and say my crystal ball in all of this has stunk so far. So I hate to have people going out and buying antigen tests that could just sit on the shelves, and they're not terribly cheap. So for right now, I would say I would not advise it, but who knows what the future holds, and I will readily eat those words if I'm wrong 2 or 3 weeks from now. So feel free to quote me on that. Along that same lines, there are, and actually Renee sent this to me, there are a host of asymptomatic testing locations across Monroe County, and then we did get one more for Wayne County. I believe the Genesee County site was a one and done. I have not heard that persisted, and Renee shaking her head yes. So the ones that we have from Monroe County in Brighton, Temple, Rith Kodesh on Elmwood Avenue. For Gates, it's Memorial Park at 160 Spencerport Road. For Rondecoit, the Public Works Building at 2629 East Ridge Road. And then Rochester, one at Benjamin Franklin High School on Norton Street, one at East High School on East Main, one at Jefferson High School at Edgerton Park, and one at Wilson Magnet School on Genesee Street. And we can copy those into our email today. The Wayne County site, which is right now scheduled for December 12th, 10 to 2, is the Lions Bus Garage on Clyde Road, and registration is already full. Thank you, Renee. So if you want to go to the one in Wayne, unfortunately, it is too late, it appears. That will all be uploaded on our website. We'll continue to keep you abreast if we hear. They are doing antigen tests. I don't know who they were, I'm sorry. But LJ was shaking her head yes, so that must be correct. Oh, you just went on mute again, Renee. Or LJ, sorry.
I think the question was meant for they being those sites are for asymptomatic testing that have been set up are antigen tests. That was the question.
I believe that is true, but I do not know that to be certain.
Yes, that is my understanding, that they're antigen tests, not because they're getting the results within 15 to 20 minutes. So it's a rapid antigen test.
Yeah, absolutely.
So again, not for symptomatic, for asymptomatic testing.
The other thing, the State Department of Health, we talked about this a little bit last week, has sent out enrollment for enrolling in the COVID vaccination program. That link was shared and was sent out. So many of you have asked how you could go about getting included in that. Definitely go and fill that out. As far as a timeline for when practices could and would receive vaccine, as of right now, I would guess it would probably be at least late January, if not later, just based upon the number of vaccines that are going to go out to doing nursing homes and frontline healthcare workers, and knowing that Pfizer from Wednesday to Friday cut their distribution anticipation in half. So now the anticipation would be if we get the volume of vaccine that is anticipated required for nursing home and frontline healthcare workers, it would take at the current delivery schedule until the end of January to be able to have enough vaccine just to vaccinate that first group. From there, we'd be talking about high risk folks and elderly. That would, at the current vaccine distribution rate, could take as much as another 2 months. So now we'd be talking, sometime towards April, May before general public could have access. Both Moderna and Pfizer are saying that they plan to be able to ramp up production, but that their current production is below what their initial estimates were. So, right now, New York State is going to receive roughly 170,000 doses of vaccine by the end of the year, with about 120 to 130,000 of those being Pfizer and about 40,000 being Moderna. Moderna and Pfizer plan to ramp up come January, but whereas they had talked about having up to 40 million doses ready to go by January 1, that now looks to be about half that. So just want to keep everybody abreast as far as plans. And then obviously the AstraZeneca and Johnson & Johnson vaccine, it's still not 100% certain whether AstraZeneca is going to have to complete a third trial before they will get approval in the United States because of their difference in utility. Remember, they had 2 trials, one that gave a half dose followed by a full dose 30 days later. That showed a 90% efficacy. They had a second trial that was the larger of the 2 that was a full dose followed by a full dose 30 days later. That showed a 62% efficacy. Because of that wide variation, they have already launched into a third trial. There is some anticipation that they may get worldwide approval based upon existing data, but that the US FDA may require completion of the third trial before they would get an emergency use authorization stateside. In which case that will probably be another couple of months before the AstraZeneca vaccine would become readily available. I don't know that for sure. I haven't heard definitively one way or the other, but the AstraZeneca obviously would be the more shelf stable of all of them currently available. And I'm not sure about a time frame for the Johnson & Johnson vaccine at this moment. So take that for what it's worth. That's all I know at this moment. The updated guidance related to pregnancy and COVID, I have not read that link yet. So I will turn it over to LJ or Renee to give that if you guys did.
Well, from a clinical perspective, no, I did not read it, but I intend to include the link in our email today.
Okay, so I'm sorry I have not yet read it.
And I have not had a chance to go through it, but I'll include a little summary to go with the link. So we'll summarize it in what we send out.
So there will be some very thoughtful things coming your way by the end of the day about pregnancy and COVID. Okay.
Probably along the lines of pregnancy, don't do it.
Exactly. But if you do it, don't get COVID. If you get both, oh well, we'll figure out something then. So
We are seriously deteriorating here.
exactly, we're falling apart. Next thing is about PPE availability. So we are working simultaneously with U of R supply chain. So U of R supply chain is doing very well. As I mentioned last week, there is now going to be a worldwide shortage of nitrile gloves. That shortage will not abate probably for the next 1 to 2 years. I have now learned more about nitrile gloves than I ever wanted to know, but for those who are interested for the trivia question, it takes a year to build a nitrile glove production and processing plant. The plants are 60 yards wide and 100 yards long. There are only 3 countries in the world that have these plants. None of those 3 countries are the United States of America. Once you have a plant, it takes about 12 months to produce the raw materials. So starting today, if we all decided we wanted to make nitrile gloves, it'll be 2 years before we really have any on the shelf. The 3 countries that were the only producers of nitrile gloves did not use nitrile gloves themselves. So India, China, they were not big utilizers of nitrile gloves. Since the COVID pandemic, they have become big draws on the nitrile glove availability themselves. So that has led to a shortage across the region. I'm sorry, I missed that. Can't read that last part. I'll come back to that one, Tim. Sorry. So what we are going to start asking is wherever possible, there's going to be certain places where we will recommend the use of the vinyl gloves because that's all we're going to have access to. But where possible in your clinic, start looking for places where where vinyl gloves would be acceptable. Truthfully, by CDC guidelines, so the CDC has approved use of vinyl gloves in all settings. The only place where it has been recommended to continue to use nitrile is really in like ICU settings and frontline inpatient settings. So for almost all of our purposes, the vinyl gloves would be acceptable. At this moment, we still have a supply of nitrile gloves available, a reasonably good supply at that. But we will not have an unending supply. So we're going to have to shift a percentage of our glove utilization to vinyl in the very near future. So just know that that's the case. We're looking for avenues, but I've been told by just about every supply manufacturer that there is no workaround at this moment for the nitrile glove solution. That's pretty much going to be vinyl. Does that mean that we would see the reiteration of latex glove? I got to imagine it's possible. I don't know what other alternatives there are to nitrile and vinyl on the market outside of latex, but I'm sure we're going to hear a lot about that in the coming months. So just know that that's on the table, and we will continue to try to maintain as much of a supply as possible. But I would start, stockpiling what you got, using nitrile where available, and sandwich bags may be the next best alternative. We'll see where that goes. The other things that are becoming a little tighter are N95s. So inpatient, they are starting today reprocessing N95s. So that I would say our utilization has not been huge at this moment, but we have found an avenue to support our current supply chain for N95s through the U of R. It would require a spot buy of where you have to buy a volume at one time. So we probably will look into doing that just to make sure we have some extra capacity on the N95s and gowns. Also, there's been a kind of steady but slower flow than you would like to see. The utilization of gowns has gone up. We have gotten a spot buy opportunity for gowns, and we are likely to pursue that as well. So just wanted you to know where we stand. Everything else is pretty status quo, acceptable for the moment. Procedure masks remain readily available, but gloves are the worst. N95s are getting tighter. Gowns have been tight. I can imagine we'll get tighter as utilization goes up and volume of cases goes up. So we're going to try to get a little bit ahead of the game on all three as much as we can. So the final question that I do not know the answer to, folks have emailed, texted, are we going red? Are we going red today? Believe it or not, the governor does not give me any insight. He did not say on his call. By all accounts, by the guidelines he put out last week, we should and would be red. We have trended, our 7-day rolling average has trended over 7% now for the last several days. Our worst, I think we hit 7.16. We are now at 7.01%, at least in the Monroe County area. But that was after a kind of good day yesterday as far as volume. So I got to imagine that we are on the edge, but have not officially been called red at this moment. I was kind of listening to his press conference to see if he was going to nod one way or the other. He did not, and he made it sound like the hospital capacity would be the more influential thing in determining red zones or pause. But he did not make any explicit indication one way or the other about changing any predetermined color at the moment. If you look at the last 3 or 4 days, the yellow zones around Monroe County are in, which is pretty much all of us, we're trending down just slightly in the last 48 hours. The orange zones were getting worse. So I've got to imagine orange will go red. Yellow qualifies for red at the moment, but it has not been explicitly implemented. I think that is everything that I wanted to cover. LJ, did you have anything that you want to speak to?
Yeah, Chad, I just want to update folks. There's been lots and lots of questions about the return to play guidance and how that is being revised. Those people who are on the Pediatric Advisory Committee heard sort of a preview of what we thought was coming. And then the AHP put out new guidance with a lot of specific recommendations on Friday. So here is what I'm going to summarize for you. Honestly, I want to give a big shout out to George Porter, who's our head of peds cardiology, who worked on this diligently, emailing back and forth, and a team of primary care pediatricians and infectious disease specialists working on this over the weekend to try to come to something that is guidance that we can actually follow, that's doable, and that is smart for kids. So the bottom line is this, that the AHP guidance does not use any age cutoff as the American College of Cardiology does, that they're recommending some form of assessment regarding cardiac symptoms for kids who have been COVID positive, and they don't draw a line around age of 12 or 15. They really put forth the importance of doing that shortly after a young person is released from their isolation period, which would be at 10 days post, 10 days post their positive COVID test. There's more responsibility for the PCPs then in terms of doing that initial cardiac risk assessment. And really, you know what those things are. There's a 14-point pre-participation evaluation that's put out by the AHP, but this in particular during COVID, this is questions about shortness of breath, chest pain, lightheadedness, syncope, finding out if a child has a past history, cardiac history, which I think we would know because they're your patients you're covering. But if it's a patient that's new to any child who ends up screening negative at A recommended, not an immediate return to play for full sports. And then for kids who do end up screening positive, whether they were asymptomatic, symptomatic, or moderately symptomatic, there is encouragement of direct involvement from cardiology. So these are some of the new things that are coming. So the cardiology team is actually looking to be ready to accept more referrals. I would just have people keep in mind, this is a relatively small number of kids. If you think about the number of children who have actually tested positive, it's less than 10% of the total numbers within our county who have tested positive. And most of those have been mild or asymptomatic. The majority have not been moderately symptomatic or significantly symptomatic. But they are going, cardiology is going to be looking to set up some specific COVID assessment days, and they will do what they're recommending happen is that if a patient is identified as having either risk factors because they had significant disease with this and symptoms, or whether they screen positive for cardiac symptoms, that those children be referred to cardiology. They will do the EKG and echo and set up a follow-up visit because they want to make sure that this moves forward as quickly as possible. Everything that's coming out at this point now is saying EKG alone may not be enough in those cases. It also does not mean that every case needs troponin, high sensitive troponin levels checked, because honestly, in peds, we don't even know what those mean. Those are usually for, I'm looking at Chad right now, that's usually for MI patients, right? You know, so we really need the cardiologist to step in and help with that. And I appreciate our team. They recognize they will need to be very facile with that. So the algorithm that we had out before is going to be pulled. There's a new one that should be finished this afternoon, along with a sort of a checklist for people to follow in terms of symptoms, what needs to be documented, and then a return to play attestation form that we can have something uniform. People can embed it in their electronic record, just as you've done with your other return to school attestations. But the things to keep in mind is we've looked at this as a team, and whether people agree with this or not, our feeling is that this should apply for kindergarten up through grade 12, because these are the kids that are going to be engaging in, if they're in school, they're engaging in PE of some sort. This does not apply to playground play. This does not apply to the preschool population. Any child who presents with symptoms obviously needs to be seen and attended to. But in terms of the screening piece, that's what we're putting forth is K through 12. I'm sure you'll have questions when you look at the documentation, but I figured if I gave you a heads up ahead of time, we've tried to make it as clear as possible. The gradual return to play guidance that's put out by the AHP references a British journal. It's very cardiology oriented, like making sure the heart rate is less than 70% of whatever. We're trying to go with that guidance, but make it doable for people with kids and for schools. So we just amended that slightly to make it more understandable what the gradual return to play is. I would say this is a document that's going to get revised because, and it's not evidence-based. So everybody is saying, well, how is it evidence-based to evaluate kids under the age of 15? It's not evidence-based to draw a line on any age at this point right now because we don't have enough evidence. So we're trying to do the best that we can with that piece. But I would say to folks, err on the side of assessing, at least asking the questions. Assessment should involve a physical exam if you can. If we go into a red zone and we have to change how we're seeing patients and do more telemedicine, this guidance at least gives a little bit of leeway to do some of that assessment through telemedicine and then bring in kids selectively based on your screening. But I would encourage folks, if they can see a patient post-COVID, that is a very, that would be an appropriate thing to do to be able to get a cardiac exam and get a blood pressure on that child. The other thing I just want to point out that people may not be aware of that I learned on Friday, back when we didn't have so many cases of COVID, the isolation releases show patients who are in isolation, all of those kids and adults were being done by medical personnel. They're no longer being done by medical personnel because there's many people who are being deployed to do isolation release. So those questions about cardiac symptoms are not being asked. It becomes our responsibility to do that. So that's why we're recommending that the primary care teams get involved. So that, I think, is everything I have to say. The only other thing is just I want to call out the questions that were in the chat. It's very confusing right now because the CDC has put forth these shortened durations of quarantine and ways to test out of quarantine. So I think that it's really important to know that New York State Department of Health has not embraced that. It's still 14 days because it's the same as 14 days with New York State. It is 14 days with Monroe County. Monroe County's not gone rogue. We're really following the state. And as that changes, or if that changes, or when it does, we'll update guidance for everyone. So thanks everybody. And I think that, oh, I'm just looking in the chat. Sorry, this was just private to me. Two things. EKG, where does EKG fit in all of that guidance? I would just say, again, it would be for those patients who screen positive, or that you'll see it in the document once it's done, but anybody who had moderate symptoms is recommended that they get EKG and echo. So that's why they are a team that they are a bucket that goes towards cardiology if they've had moderate symptoms, and they define moderate symptoms. And then the other thing is just, one of the members of the team just pointed out to me, this is not evidence-based, but it's evidence-informed based on observational data. I think what I'm trying to say is we haven't observed a whole lot yet to know, but it is as informed as it can be. So thanks. That's it.
And I will also piggyback on that and say for the adult data, it's almost the exact same recommendation. So if the adult had moderate or worse symptoms, that they should engage in activity slower, but should have an EKG. Certainly if they're having any symptoms, troponin, and if there's any abnormalities, get an echocardiogram and be seen by cardiology. So that guidance really hasn't changed as of late. For mild or asymptomatic adults, they should resume, if they've been known COVID positive, they should resume activity slowly and work their way up over the course of weeks. Ed Lewis posted he wanted some good news. So the good news is on Friday, they released a study that showed the incidence of COVID myocarditis in adults was actually lower than what we had initially seen in other studies. So that was good news. That's all I got though. Other than that, not a lot of great news, unfortunately. So, and
Chad,
they might get some machines.
Ed Lewis also just put forward a question about whether cardiology has the capacity to see this. And that honestly, it's okay. That's a valid question. It's the question I was asking all weekend, like, how can we make this doable? Because we recognize that for some of our specialists, there's significant wait lists now. They recognize that they will need to set this up in a way that is as fluid as possible, and that they will have to designate some specific clinical time, a couple of COVID clinics if need be during this, and they have affirmed that they will do that. And that's coming from George Porter and also the Dr. Notter, who's the head of cardiology for our region. So
thank you, LJ.
No, you're welcome. It's exactly the right question, Ed, and that was what I was worried about.
Yeah, and sorry for all the questions. One of the issues that I've been dealing with, and I don't know what other pediatricians and family practitioners are, but the number of kids who are being exposed in youth sports, and I'm all for youth sports, but I'm getting deluged with questions. I heard from a mother that somebody on the team tested positive. What do we do? I mean, I'm giving them standard answers, but I guess maybe not letting these kids play in youth sports for 2 months might help cut down the numbers. Facetiously.
Well, Ed, it's a great question. I'm sure other people are nodding. Their screens are blocked out, but I suspect that they are nodding as well. I think that if we go red, that does do something to the other youth sports things, and I do think that they should be. It's different rules. They've not been adhering. Some have, but many have been going around the rules, and that's what we can't do anymore. I think it's really good that we're trying to keep our kids in school. I think that's super important. But I think beyond that, we just got to stop as a whole community. So I agree.
Yeah, I just had this conversation this weekend about another travel team that was going out of state, and dance competition that was taking place with the kids in a room, starting 6 feet apart, but then dancing and kind of crossing paths with each other. It's almost impossible. I mean, I think that's just the reality of the game. I'm surprised youth sports have lasted as long as they are. I mean, I think we want the kids to be able to be involved as they can, but it's been a mess, that's for sure. So
Right. And I think the last thing I would just say on the AAP guidance, actually the bulk of the AAP guidance was devoted to paragraphs upon paragraphs saying that now youth should wear their masks throughout participation, not just on the sidelines, but when they're playing. So that was a big thing on the masking guidance, with only a couple of exceptions for sports. So we'll just give you the link to that so you can read all that yourselves. I think that's, to me, that feels like more common sense right now than anything else. But a lot of this feels like common sense sometimes.
whether or not people follow, it's another story.
Yes, exactly.
Renee, did you have anything you wanted to add in?
Just that there's a behavioral health call tomorrow at 12:15. And please, for those of you that are on the PPE dole, please fill out your survey. It closes tomorrow morning. And PPE pickup will be Wednesday, usual time, 9 to 10:30 at Corporate Woods.
Sounds beautiful. All right. With 3 minutes remaining, we will close unless people have other questions they want to put forward. Seeing none, we will call it a day. So we will see you back tomorrow at noon for the behavioral health call, and then Wednesday at noon for our twice a week now iteration of this call. Feel free to send those emails if other questions or issues come up. Otherwise, we will have a new and hopefully better story for you on Wednesday. Thanks,
Not noon, 12:15.
12:15. That's right. Sorry. Close enough. Come at noon. We'll be early. We'll do tricks.
Bye.
Take care, guys.
Thanks.
Bye.